name is Candace Hilton. I go by Candy. I'm the house manager at Grace House Akron, and today I am doing a presentation on student orientation for nursing students here at Grace House, and we'll begin with just going over a few things about Grace House's background and story. So Grace House Akron has been open for almost 3 years. This September, we'll be celebrating our 3rd year. And so the mission of Grace House Akron is to provide a loving home for indigent, homeless, and abandoned individuals at the end of life. This home provides shelter and a safe shelter for those individuals, care with dignity and compassion, and a nurturing environment for them who have terminal illnesses. Our vision here at Grace House is to offer access to compassionate care and comfort at the end of life for those individuals in this area. We believe every member of our community should have access to end-of-life care. So with that said, because Grace House is a nonprofit organization, our organizational structure consists of a board who meets a few times a year, our executive director, who is also our co-owner, her name is Holly Klein. Again, I am the house manager. Then we have an executive assistant, her name is Joanna. Our development director, her name is Amanda. We have a volunteer director, Demi, and we have social media marketing director, her name is Sarah. It also consists of our caregivers who work each shift to provide the care necessary for our residents, as well as our volunteers. We do consider them a part of our staff. The criteria for a person being admitted here to Grace House, they must be enrolled in a hospice program. So all of the residents that are here, that is the main criteria, that they have to be on hospice services. They also must not either have a caregiver or they have limited resources, and we do not accept any individuals that are on injectable medications. So if they're still receiving IV or IM medications, we are unable to take those residents. All of our money donations, it comes from funding that's provided. The community donates. We have a lot of donors that provide those finances that we need to keep Grace House going on a day-to-day basis. We are partnered with many of the hospices within our area, as well as Neomed, University of Akron, which you're aware of as you all are students there. And then we have a good partnership with the Humane Society. Because our home is pet friendly, the Humane Society provides services that will allow those pets to be checked out and get their shots and everything up to date prior to them staying here at the house with their loved one. So what is Grace House? So first of all, we are not a hospice. We are a home for people who are homeless or alone at the end of life. So basically, our home serves as their home. Our caregivers are an extension of their family. We call the hospice that the resident is on service with in case there's any concerns or medical questions or things that may have changed in their symptoms. We reach out to them just as if they were at home and a family member would reach out to them. Hospices will visit Grace House, so their staff comes in to see the resident just as if they were at their own home. And again, we partner with many of the hospices in the area. Grace House, Akron, and the hospices. So just some basics about hospice. There's a life expectancy of 6 months or less for a person to be on service with hospice if the disease runs its natural course. So it's not saying that that person only has 6 months or less to live, but if things should go the way that they intend, depending on the disease that they have, it could be that 6 months or less. Hospice treats symptoms, not the disease. So they're just looking to manage those symptoms that they may have, whether it be pain, nausea, vomiting, diarrhea, shortness of breath, agitation, anxiety. to keep them manageable so that they have more good days versus bad days. Who will you see at Grace House? You'll see lots of people come in and out of our house on a day-to-day basis. There'll be hospice nurses, sometimes the medical directors or physicians of the hospice. You'll definitely see hospice aides, the chaplains that are affiliated with that hospice, and social workers. We get lots of visitors, residents, family members. We get students such as yourselves, donors, people within the community that like to donate their time or donate their finances to our home, as well as our volunteers, which I mentioned earlier. They really are a part of our staff. So Grace House residents, as I mentioned before, they're either homeless, have some type of housing insecurity, alone. They may have a background of mental illness. We do get some veterans. They may have a background of addiction issues as well as cultural differences. So at the end of life, some things that we just like for you to keep in mind, and these are things that may be a review to you as you are, most of you are seniors in your nursing program. Standard precautions you would use with any resident, regardless if you know they have a suspected infection or not. Assume that their blood or body fluids may be infectious, so we ask that you make sure you're still doing the proper use of PPEs like gloves when you're providing personal care, making sure that you have good hand hygiene, and if you have a cough or any respiratory condition, that you're wearing a mask and using proper cough etiquette. We do have Purell dispensers in each of the residents' rooms, but each resident's room also has their own restroom with a sink that you can wash your hands with soap and water. Some things to consider when you're going into the resident's room here is just making sure that their basic needs are met. Sometimes we want to think that there may be something that you have to reach out to hospice like ASAP, but let's just make sure first that everything that their basics are met first. Are they hungry? Are they having any pain? Have they recently maybe just want a snack versus a full meal? Do they need anything to drink? Are they nauseous or anxious? Just looking to check with them to see if any of those things are issues before we reach out to hospice. Sometimes it may be that they just need to develop a rapport with you and develop that trust before they feel comfortable enough to discuss the things that they might really need. So meet them where they are on their journey and just know that that trust gets built over time. But we're always here, the caregivers as well as myself, that we can always intervene if that is needed. Some things to consider as well as the stages of dying. You will see residents go through some of these stages. Sometimes they go through all of them. Sometimes they may just go through a few of them. They may go through a couple and then go back to the beginning, but denial and isolation, anger, bargaining, depression, and acceptance. So they may not go through them sequentially, but they, again, could go through denial and isolation, then go through anger, and then they may go back to denial. So it just depends, but again, we meet them where they are on their journey. So some things that we probably have all said as we are giving care to patients, residents, that may not be as helpful for them to hear at this point in time in their life is things like, that happened a long time ago, or I'm sure they have forgiven you, you did the best you could, it wasn't your fault. So just be mindful of saying things like that. Some things that may be more helpful is saying something like, well, I know about grief, but I don't know about your grief. I can see you have a lot of love in your heart for blank, blank, blank. I wish I had something profound to tell you, but I don't. Or just simply saying, how can I help? to let them know that you're there, you're concerned, but how is it that you see that I can help you in this moment? So those are more sensitive responses or things that may be of more help to them at that time. So as a resident is approaching death, you may see things emotionally change in the resident. They may become more withdrawn. They may begin to let go, and they're not really socializing like they did at one time. They may have visions or see people or speak with people that no one else is able to see. Sometimes it's family members that have died before them. They may become restless and have agitation. They may have some unusual communication that may be somewhat out of their character. And then they may start to say their goodbyes to family members. And these are all normal emotional changes that you could see someone go through. As far as their spiritual care, and when you come the day that you are here to do your clinical, I'll show you a video by one of our chaplains with Summa Hospice and palliative care. His name is Shannon Blower. But for the purposes of this, I'm just going to briefly go over a little bit about what spirituality is not and what it is. So first off, spirituality is not morality. That's more of spiritual pain that can occur if there is a conflict with moral code. Psychology, it's not psychology. That deals more with emotions and relationships, which can cause spiritual pain. It's more of the why versus the how. And religion, so spirituality is not religion. Which is more of a systems attempt to address needs while providing that moral structure. What is spirituality? Those things above human limitations, like faith, hope, loyalty, and love, the things that we most seek in life that can't be proven. It gives purpose and meaning on an individual level. Every individual has a unique journey. And so just think of questions like, who am I once everything is stripped away? What have I contributed to the lives of others? What do I fear? And what do I value? Those questions, usually the answers to those are more in line of what spirituality is for a person. So again, Shannon will, the video that he does, it goes into more detail and explanation of what spirituality is. And it's only like 9 minutes, so we'll show that when you come to your session here. With that said, something to keep in mind is that not just as a physical pain can be a reality for our residents, but spiritual pain can as well. So some outward things that you may see from the inner spiritual pain might be anger, rage, bitterness, and these may be things that are directed towards you, but there's nothing personal that you should take as a result of it. These are things that may come as a result of a person having unfinished business, or there may be some relationships that they don't have mended at that point in time. There may be lots of things circumstances that they've dealt with that they just have not been able to have any closure with. So actively listening and respecting them in those moments, and again, not taking it personally. There's chaplains within their hospice staff that can come see them, and Grace House has a spiritual advisory board that has a different spiritual advisor come out each week, but they alternate and rotate each month of who that is, but they can come out and offer that assistance as well. Offering them some just calming environments, soft music, dimming the lights, and really just letting them know that you're here and that they're not by themselves. And then keeping in mind that it's not for us to fix, it's just to let them know that we're here and we're able to be of help in any way we can to help them through that pain. Since we've discussed spiritual pain, we're now going to talk about the physical. Physical pain may not be controlled until all other types of pain are addressed, which, like I said, spiritual pain, there can be emotional pain. But the physical pain, you may see grimacing, you may hear them moan, there may be change in activity, they might get angry. Those all may be signs of pain, as well as restlessness. Ask the resident at that point in time if they are in pain, if they're uncomfortable, or if they're just plain anxious. And then you would just let our staff know, whether it be the caregiver that's on shift that moment or myself as the house manager. Ways that we can help manage the pain: you can have them do some deep breathing, maybe give light massage. Those are things that you as a student would be able to do. Maybe do some distracting activities. So if it's something that they enjoy doing, like listening to music or coloring, or we have a lot of the adult coloring books, or just having the TV on and having some background noise, that sometimes helps. Repositioning a person could also help, and then us maybe just reaching out to spiritual care if that is something that they need at that point in time. So things that you could see in the final weeks leading up to a person's death here at Grace House, typically we see, I think the longest since I've been here that I've known a resident to be here is maybe 6 months. Sometimes that actively dying phase comes faster for some than others, but you usually see them start to sleep a lot more, especially during the day. They might be a little more restless and awake at night. They'll start to eat less, drink less, and they may just flat out not have an appetite at all. They'll start to have difficulty swallowing because the muscles that allows them to swallow are getting weaker every day. They have increased weakness, generalized weakness all over. They may be bedbound, have complaints of body feeling just heavy because they're so weak. They may not be able to concentrate or really focus. Their attention span might be a little shorter. There may be increased confusion, restlessness, some vivid dreams. May see people who are not seen by others, which we had talked about earlier. So, final days, you may see again the increased restlessness. They may start to pick at things like their gown and taking it on and off. Linen, become more anxious, fearful, lonely, especially at night. This may be more what you see at night. Maybe loss of bowel control or bladder control. Maybe moaning or crying, spending less time awake and sleeping more, again, not able to eat or drink. There may be some oral secretions that start to increase. The lungs may become more congested. So at that point, things that you could do outside of us medicating the person for those things would be to reposition or raise the head of the bed. That always is helpful to manage those secretions. And there may be a decrease in voice quality at that point. They may not be able to have the volume that they once did with their voice. And so their vision might become blurred. So announcing yourself when you go in the room, because they may not have a good vision to know who's coming in, and really speaking so that they can hear you and know who it is that's coming in the room and what you're doing is real important. Some other things that you may see are the arms and legs may become discolored with like a bluish color, which is called mottling. Heart rate and breathing becomes irregular. They may not be able to respond like we are used to them responding. So they may not be alert. They may be sleeping, but just assume that they can still hear you. So you still want to speak to them as though they can respond back to you. Know that there may be more pressure in the areas such as their heels and coccyx and shoulders, and sometimes their ears. That may also start to turn like a dark purple and could start to break open, but that is because the body is starting to shut down, and it just may cause pressure sores in those areas. So it still is real important for you to reposition frequently, and we have pillows that you can use to kind of support those areas, just to keep them comfortable. Moaning sometimes can occur, not so much because they are in pain. These final days, it could be that it's just because of their vocal cords when they're exhaling. That may be a sound that you just hear. So keep that in mind as well. And these are final days to hours for them. And then just understand that with grief, that every person is very individualized. Grief can be experienced not just by the family members, but also by the individual. They're grieving the fact that even though they know that they're dying, that they're not able to do what they were able to do at one time, that they're so weak. And the fact that they're not going to be here for their loved ones. I know a lot of individuals that are real concerned with that. Even when we know that the death is expected, it's still a loss. Stages that we talked about earlier, the denial and isolation and anger and bargaining, those things may start to be seen as well by not just the family members, but also the resident. So it's just good for them to be able, if they are able to talk about any of those things, and really helping them remember good things and good times that they've had with their family, and the family remembering those moments with their loved one. So just as a quick review, there's some common medications that are used in hospice, and I'll give you all a handout when you do come. So I'll just mention a few of these, but the common ones that most hospices use: Tylenol suppositories are used for fever, oxycodone, morphine, sulfate are used for more immediate, like as needed pain. Lefsin is used for congestions and secretions. Haldol, even though we're probably most of you are used to that being used for as an antipsychotic, it can be very beneficial and used for nausea and vomiting, as well as agitation for those individuals who may have terminal restlessness and agitation. Anxiety and shortness of breath, Ativan or lorazepam is used. Most of the time for nausea and vomiting, you'll see Haldol, sometimes Zofran, but for the most part, I see Haldol. Every now and again, Compazine and Phenergan, depending on the hospice agency that is managing the resident's care. They'll also use long-acting pain medication and MS-Contin or methadone, and that'll be scheduled, but then they'll still have PRN medications for pain as well. A lot of the medications that are used as needed, like Ativan, that can be used for anxiety and shortness of breath, that can be crushed. And what they do, if a person is unable to swallow a pill, we crush it, we put a little bit of water in it, and then we pull it up in an oral syringe, and we can give that sublingually. Even if you can't get under the tongue, it can be given on the sides of the mouth so that it's absorbed by the lining of the mouth in that way. Oxycodone also can be crushed and given in that manner as well. Again, Tylenol mostly is given for the fever that could occur as a person is in those final days. And that is usually because the mild pain, it can be given for mild pain, but most times the hospices are ordering the stronger medications due to people's pain being a little more severe. Haldol is also another medication for the nausea and vomiting and agitation that can be crushed and slurried in case that person is not able to swallow a pill. Morphine is a lot of times ordered as a liquid, and that's called Roxanol, but usually we just refer to it as liquid morphine. And if it gets to a point where they're not able to swallow the pill, most hospices are able to just order it as a liquid, and they'll let us know 0.5 or 1 milliliter. And sometimes towards the end, it can be given more frequently, like every hour. I've seen it inpatient wise setting given every 15 minutes if the person was really having shortness of breath or pain in those final days or hours of life. Dilaudid is also another pain medication that is given as needed, and that can be for pain and shortness of breath. And that comes in a liquid as well, but that one can be crushed too if need be. The only ones, like I said, methadone and MS-Contin, they're longer acting, so they can't be crushed. So if it gets to a point where a resident is unable to swallow those pills, then they would just switch them to the more immediate release PRN medications, but they would be able to take them more frequently. Some of our residents, especially those who have like lung cancers or any type of respiratory conditions, they'll order either inhalers or aerosol nebulizers for them to take either as needed or scheduled, or sometimes both. And we keep in mind most of the time by this point in their condition, they've not really had any of these side effects. Maybe early on they may have, but stomach upset is something that they can have if they are taking like a dual neb. But most times you'll see the pulse increase after they take their dose of the dual neb or albuterol, whether it be inhaler or nebulizer. And then, as I had mentioned earlier, Levsin, that is a medication that we use to reduce secretions. Doesn't take it away completely, but it does manage it so that they're more comfortable as those secretions build up in their lungs. And it starts to work within a few minutes and usually lasts so it can be given every 4 to 6 hours. That is one that is more common now. When I first started providing hospice care years ago, we used to use atropine drops. I don't think they use that very much anymore, as well as Robenol. I think they may use that more inpatient, but Levsin we'll see on the outpatient setting like Grace House. For those patients who are having difficulty with constipation, because we know with any pain medications, and especially taking them at the frequency and the amount that our residents most likely do, that is a real issue. So a lot of times hospices will just order medications and have them on it proactively. So the common ones are Senecot, which are pills, and they can go up in amount on those, like 1 twice a day, 2 twice a day. They can continue to go up on amount, but that usually works well for most people. And then they can also order Dulcolax suppositories, especially when it gets to a point where they're not able to swallow pills. We have tons of mouth swabs here. When it comes to those final days, you're really making sure that we provide that mouth care regularly throughout the day. And one rule of thumb is when we do repositioning of the resident, at that point in time, after we get them situated, just providing that mouth care. We do have ice water, and you can just put the mouth or the swab in the ice water and kind of push up against the cup with the swab to get the excess fluid off, and then just swab their mouth out, get their lips. And we also would encourage like a lip moisturizer that's not petroleum based. Most of our patients by that point in time are wearing oxygen, so we have to be careful not to use anything that would be petroleum based if they have oxygen on. Another sign you would see is fatigue. So encouraging the resident to pace themselves, not exerting too much energy at one time. We try to keep everything in close proximity to them on their bedside table. Um, and as the disease progresses, just really letting them know that, you know, we'll try to minimize their activities so they don't have to try to get up and out of bed, especially if it comes to walking to the restroom or getting up to the bedside commode. At that point in time, it may be that they have to get a Foley catheter just so that they're not exerting all that extra energy that it takes to get up. So some things that you would see as death is approaching and the resident is declining. The breathing can become congested, rapid, or very slow. Shallow, the breathing can become shallow. You may start to see periods of apnea where they go for an extended amount of time without taking a breath. Decreased urine output. Their hands, feet, and knees become mottled, like we discussed earlier. They may have increased restlessness, increased sleeping, periods of sleep, and it may be that they can't close their eyes and you're wondering, are they asleep? Are they awake? It just may be difficult for them to close their eyes. But again, still speak with them and announce yourself when you go in the room and let them know what you're doing before you do it because they can still hear you. When a person starts to decline and we see signs that death is approaching, we want to always make sure that the hospice service that they're on service with is aware and know. Instruct that we don't have a time, just that we're noticing changes at that point. And by then, most of the time, the hospice nurse has already called and discussed this with family. If there's no family, we can request a volunteer to sit vigil with the resident, and we've done that often here in the last few months, actually. We can put on soft music and we can continue to talk to the resident, just let them know, like I said, what you're doing. Don't try to wake up or give water to that person because 9 times out of 10 they're not able to swallow at this point. But just doing things that would bring them comfort. So it may be medications and talking to the family and friends at that point in time. They may find joy in reminiscing, talking about the person, things that they did, looking at pictures. Sometimes just sitting with them is very helpful for the family at that time. Physical care that we can provide in the moments that they're getting closer to death, repositioning if it's not going to cause them too much pain or discomfort, keeping them dry and clean, monitoring if they need to be changed, and keeping their mouth moist, like we talked about, and if they need oxygen at that point in time. When we have a resident that dies, if the hospice nurse is not here visiting, it seems like most of our deaths occur overnight. It's at that point our caregiver would call the administrator that's on call, so that would either be myself or Holly, and then we would have them call the hospice that the resident had been on service with, close the door. The caregiver would close the door. The hospice staff would then call the funeral home and any family members. Our caregiver would complete a death report, and when the hospice nurse comes out to visit and actually pronounce the patient dead, they would make sure that the medications are disposed of, as well as make sure all the DME is picked up. So our caregivers would do everything else as far as preparing the person's body for the funeral home and making sure that the room and all of that is picked up and clean once the equipment is picked up. So that is the extent of this session. and we will go through more when you do come for your clinical. If you have questions regarding this information, please write those questions down and we can go over that information the day that you are here. And then I'll give you the handout for this presentation. So I thank you for your time, and we'll see you when you come to Grace House. Have a great day.